disclosure, right? I haven't received any information about that, but I don't think she has. She will be talking about evidence-based psychotherapies for aggressive children and adolescents. Let me tell you a little bit about Dr. Katsanis. I think most of you may already know her. She's one of us, part of our department. And she did her BA and Master's in psychology from Carleton University, Ottawa, Canada, and then a PhD in psychology, clinical psychology, University of Minnesota, Minneapolis. And presently, she's Associate Professor of Clinical Psychiatry and Psychology here at University of Arizona. She runs our anxiety disorder clinic for the children and teenagers. And she's actively involved in the internship program, child psychiatry fellowship program, and the child internship training. And she has received several scholarships, awards, honors. She has, research awards and teaching awards. And I was looking at her publication. She has over 35 peer-reviewed articles published, and she had made numerous presentations. So let's welcome Dr. Katsanis.
Thank you. Thank you for being here today. I'm sorry I have to exit, but it seems that the title of this presentation kind of throws me off because I apologize, but somehow the presentation that I had copied on man. It's not here. Oh. I need to go to my office. I'm sorry, I brought in the wrong presentation. I apologize. I'll be right back. Okay, so today I'm going to be talking to you about various treatments that have found to be evidence-based, that have enough evidence to indicate that there could be good choices for children and adolescents that exhibit aggressive and violent behaviors. And I want to start out by displaying some epidemiological data regarding aggressive behavior in children. And as you can see with the data I present up there, that there's been a significant source of morbidity and mortality involving aggression and violence involving kids. And also that this data, this incidence has been increasing over time. And over the years, we've seen 158% number of homicide rates being increased among boys and 64% among girls. Also, the number of aggravated assaults I have here have been increased by 88%. The problem with violence has been highlighted, as we know, with the high school shootings that really took headlines and put it to our attention of how violence and aggression can affect so many people at so many different levels. Also, what we've seen over the years is that teenagers doing time in adult prisons has also more than doubled. Again, all this information points out of why it's important to do research and develop therapeutic methods to address this problem, and why a lot of money has gone to address this problem. If delinquent youths are not, there's no intervention with delinquent youths, what we see is that an increase among them of drinking, high-risk behaviors, substance abuse, reckless driving, domestic violence, and so on. What we know about the aggression and violence is that it's stable over time. And there's been a lot of data that looked into that and have shown stability coefficients that sometimes people resemble to intellectual functioning. So we see stability coefficients that resemble IQ stability. And some studies show anywhere from 0.34 to 0.68 correlations over time. There's been a lot of longitudinal data, again, looking at stability of violence and aggressive behavior over time. They looked at preschool kids. Some studies look at preschool kids and then they followed over time, and they've shown that preschool kids that have very difficult to manage, eventually by age 8 or age 13, they're more likely to be diagnosed with oppositional defiant disorder or conduct disorder. When I put there retrospective research, that indicates kind of looking forward and looking back to people, adults that are committing violent crimes. And again, when you look retrospectively, you see that a lot of these people, when they were young, they were getting into problems. They were all displaying aggressive behaviors and violent behaviors, as indicated by looking at police records, referrals to the school, suspensions, and so on. Also, multi-generational data is another means of determining stability over time of aggressive behavior. And what we know is that, unfortunately, aggressive behavior and violence does propagate across families, and that we see that a lot of times parents do tend to have kids that are also aggressive. And there have been studies that looked at aggressive levels of behavior in parents of 8-year-olds. And then, against longitudinal data, looked at the kids when they were 30-year-old and looked back at the parents' aggression level when they were 8, and they saw high correlations, again showing to us how things are related and how aggressive behavior and violence, should we not intervene, is not likely to change. I list here some risk factors pertaining to violence and aggression, and it's important to keep in mind when I list all these risk factors, because it points out to in what areas we need to intervene when we're dealing with patients. You know, what are the risk factors and how can we intervene, and what are the needs that they have to bring about change and shift the trajectory into a more pro-social direction. The factors are individual, family, school, social, environmental, and situational. And what research shows us is that it's not so matter one factor versus the other that makes a difference but rather the aggregate number of risk factors present that makes a difference. So we start out with pregnancy, perinatal-related factors, such as when the mothers of these children are abusing substances, consume alcohol, they smoke during pregnancy, engage in poor nutrition, and then we would have results of premature birth weight and developmental delays and so on. We have research that shows of kids that have a difficult temperament. They are more irritable, impulsive, uninhibited. They're more likely to evoke from their parents hostile and avoidance behaviors. So these kids that are troublesome, have troublesome temperaments, are more likely parents to be aggressive towards them, aggress towards them. Also, there's been studies that looked at infants that have difficult temperament, and they found that they elicit harsh parenting from their caretakers by age 4. Looking at a socialization, we have kids that could be stubborn, resisting control, they're difficult to manage, they have a lot of tantrums, and again, that will start to begin the coercive maladaptive cycle between the parent and the child. And of course, kids that show observable contact problems at early age. Also, poor peer relations, inability of kids to play cooperatively with others, being interruptive, being socially mature, have been shown to correlate with increased levels of violence and aggression. Poor academic progress. There's questions, I have there low IQ, truancy, low bonding with school. And usually in terms of getting to the low bonding with school, kids will be asked, if you were to miss a class, if you were to miss a day in school, who other than your peers will know you're not there, that will miss you having you there? And I guess this question is used to assess the amount of bonding that exists between the child and the school. Is there a person, a teacher, a coach that would be looking out for them? And to what extent they feel that they're not just an anonymous number, but that someone is aware of their existence? Also, what we know is that kids, adolescents that have been incarcerated, we know data that would show that they have 5 years, they're 5 years below expected level in reading. Disciplinary contacts with the principal, 6 to 9% of kids account for 50% of the referrals to the principal. Again, we see a lot of kids that would have aggressive behaviors at school. They would be more likely to be members of gangs, have weapons in the possession, use marijuana, etc. Also, these kids that are aggressive or engage in violent behaviors show a tendency to associate with deviant peers. A lot of times it's them engaging in antisocial acts, and therefore prosocial peers will start avoiding them. So then they start hanging out with the wrong crowd that again encourages more aggressive and violent behaviors. Substance use, them using substances, also having accessibility to weapons and owning weapons, and of course living in communities, in places where weapons or aggressive behavior is condoned. Poor parenting practices is another big one, in that we're looking at monitoring, parental monitoring or supervision. A lot of times we see families that the parent is not as involved, the parent may be rejecting, and also the parent may be engaging in inconsistent, harsh punishment. Also, we see families that are unstable. There's a lot of marital distress, domestic violence, and also there's a lot of conflict between the parent and the child. So we'll see a lot of polemic situations at home. Child maltreatment. Kids that have been physically abused when they were young. They display by age 7 or 8 a lot of aggressive and violent behaviors. Again, looking at kids that have been abused in an early age and then showing that these kids eventually start aggressing themselves. Also, early physical abuse, what it does is it predicts the development of the child to be hypervigilant to hostile cues. So the kid that is being abused early in age, they become more aware and more looking out, their antennas are out to see hostility in comments or what is going on around them. And also have an attributional bias and also aggressive problem solving. So in situations, the solution would be more to aggress than to find a solution that is less likely to bring about violence or a difficult outcome. Insecure attachment with parents. Again, looking at the attachment literature, we see kids that are not connected with their parents as well, or they don't have any other connections with organizations or activities. Either that will be religious, as in churches, or sports-related activities. Kids may have comorbid disorders. As mentioned earlier, gang membership and dropping out of school. And a lot of times, the result of aggression and violence could be the result of the system not working well for them. And I put down lack of communication or collaboration. A lot of times what we see is either the school is not paying attention to the parents' complaints, either the school is not being aware that the child or the adolescent has kind of increasingly becoming more violent, or there's a poor communication between social workers and the school and the police, and kids fall through the cracks. And I guess in this situation, system failure was identified as being one cause of the Columbine high school shooting. So today I'll be talking about evidence-based therapies, and I have 3 listed: parent management training, cognitive problem-solving skills training, and multi-systemic therapy. And these treatments, there's been, again, because the problem is affecting so many levels of our society, there's been a lot of treatments that have been put forth. And in one article, overview article, it was cited that 550 therapies exist for kids that aggress and are violent. And these 3 are the ones that have demonstrated the most efficacy and have been systematically evaluated with control studies and follow-up data and long-term data. And we'll start with parent management training. And what it means is parent management training is training parents to change the kids' behavior at home. A lot of times we have situations where the parent may be aggressing at home, even though they're not aware of how they're promoting or teaching the child to aggress. So how is the parent dealing with anger and frustration at home? Is the father punching in walls? Is he throwing things across the room and breaking them? So kind of modeling to the child of what you do with your frustration. So with looking at parents and their parenting techniques and how they go about disciplining the child would help to teach the parents how to reinforce, see to what extent the parents reinforce deviant behavior, to what extent they're using ineffective commands, harsh punishment, and they fail to attend to appropriate behavior. And what I have here is I'll show you a clip of a parent management training teaching video that would illustrate some of problematic behaviors that some parents may engage in. Whoops. It was doing okay in my office. I got it. I need to.
A common trap adults often fall into is to attend to the children who are misbehaving, while at the same time ignoring other children who are behaving appropriately. Watch this happen in the next vignettes and think about how you would handle these situations differently.
Stand over here on the carpet. Come over here. Let's look and see what you can play with. I'm sorry, but Mama told you that if you put sand on the floor, then you might have to... Well, in a little while you can try again. Come over here.
So again, what you see here is the parent paying attention to the kid that is making the most noise, and the kid that is quietly sitting playing is not attended to. So in a sense, the parent, since kids do want attention from their caregivers, then the kid learns that the way they get attention and they get the mom involved is if they're acting out. So in terms of teaching parents adaptive behaviors, you want parents to be able to establish clear rules, provide positive reinforcement when the kids are doing well, use mild forms of punishment, and also negotiate compromises. The important part, again, is to be able to look at how the commands that the parent is using may be escalating aggressive behavior or acting out instead of de-escalating. The treatment characteristics of parent management training involves, again, treatment with the parents, helping the parents identify problem behaviors at home and new ways of dealing with these behaviors, and using either videos or role-playing to be able to develop new skills of parenting. The treatment duration varies with the child. In mild situations, it can be as long as 6 to 8 weeks. When we have more severe problem behaviors, it can be as long as 12 weeks to 25 weeks. And it can be applied individually or in a group setting. And the video clip that I showed you came from the Incredible Years Parent Training Program by Webster Stratton that has shown extremely well on good data. Outcome data has been studied very well. It has a lot of components, home assignments, group support. There's an encouragement of the parents that participate in the group to encourage each other in between treatments and share information and so on. So this is a program that has a lot of validity and reliability in its outcome. With the parent management training program, we're promoting parents' problem-solving skills, try to strengthen the positive ones, teaching the parents how to play with the child. And again, teaching the parent how to play with the child refers to them developing more positive credits with the child. So developing, a lot of times parents come to you, and at the time they come to you for help, they're fed up. They see the child as being evil, or they see the child as being a problem kid, and they cannot see any solution ahead. And they have distanced themselves with the kid. So learning how to spend quality time and play time with the kid can help develop the credits that you need. So therefore, when you curtail problem behaviors or you put your kid time out, you still have a lot of positive that you're relying on. You still have a lot of positive experiences that you can still use up credit for. Children are motivated with rewards and teaching parents how to use these rewards with children. Praising, and that's another part that it's helpful to, another part that training parents how to effectively praise the child. So therefore, things that you indicate to the child are in a positive spin as opposed to not in a negative spin. Ways to handle misbehavior, and that will mean ignoring problem behavior, like the clip we saw that the attention was placed on the kid with the problem behavior. The good thing to have been done was to not pay attention to the kid, pay attention to the kid that is playing, or try to distract the kid that is acting out. Time out for aggressive behavior, teaching parents how to effectively use time out, and also problem solving. Another teaching parenting technique that the parents need to learn is logical and natural consequences. So therefore, if the kid is angry, rips the book, the kid needs to put the book together, or they have to work to earn money to pay for the book. Or if the kid writes on the wall, then the kid has to paint the wall and repair what they've done. I have here a clip that shows appropriate reaction to misbehavior.
Notice how the next two parents ignore the misbehavior and then give attention back to their children as soon as they stop misbehaving.
The mom is having a hard time ignoring. Oh, that's it. So now we pay attention to the kid because they stop crying, and you pay attention to the kid when they're not engaging in the behaviors that you want to eliminate. Now, parent management training has had numerous control outcome trials. Long-term outcome, as I mentioned to you, are very strong. And data, hard data, such as school truancy, police contacts, arrest rates, institutionalization, again, they've shown a big difference for parents, families that have engaged in parent management training in terms of the difference that it makes in the long run in the outcome of these kids. And also, there's been some studies that show that the treatment gains have been maintained even 10 or 14 years later, when families that have gone through PMT have been compared with controls that didn't get this kind of treatment. Also, what we see as a side effect of PMT is that is an improvement in the siblings' relations, so there's less conflict between brothers and sisters, and also maternal psychopathology, so less depression, less adjustment issues in the mother. What are the predictive factors that contribute to outcome? What I list here is things that predict poor outcome. So to the extent that there is poor family socioeconomic status, to the extent that there's a lot of marital discord, a lot of conflict at home, parents are a lot under stress, there's a lot of social support, these are all factors that predict who's going to stay in treatment, what is the magnitude of change that the families are going to experience, and to what extent change will be maintained at follow-up. So PMT is the most well-researched therapy technique. It has been looked at and tested for kids anywhere as young as 2 and all the way up to 17 years of age, and has shown the data suggests that it may be more efficacious for the younger, the pre-adolescent group, more so than the adolescent group. And some hypotheses that have been put forward to explain that is that perhaps with the older kids, there's greater severity of the symptoms that they're experiencing, and therefore the intervention may not be as effective when the symptoms are very, very severe. One of the disadvantages of the PMT is that it places heavy demands on parents. Parents need to be educated, have to learn a lot of material about behavior, changes of behavior, contingency management. They have to do a lot of homework, fill out forms, homework exercises, monitoring, etc. And that could be overbearing for some families that are parents that are taxed. And here I have illustrate other ways to cope with pressures. I'm forming a support group for women who feel overwhelmed by cooking, children, and housework. We meet every weeknight from 5 to 10. So if there are any parents out there that are interested in forming this group, please see me after the lecture. So here I have resources for clinicians, and I think they're also in your handout. Some books that have been found very helpful, again, for people who want to dwell in and learn more about PMT. And this is a listed program, the PMT program, the Credible Years Parent Training Program by Webster and Stratton. Cognitive problem-solving skills training is, again, the second therapy, evidence-based therapy that has had a lot of support in showing changes in aggressive and violent behavior in kids. And what cognitive problem-solving skills training refers to is a broad class of constructs of how people perceive the code, the process the world, and experience the world. So cognitive processing of how the information, incoming information. So we have here a cartoon about distortion of aggressive information or negative information. This is a special hearing aid. It filters out criticism and amplifies compliments. And fortunately, in the absence of this hearing aid, we have to rely on cognitive ways, cognitive skills that we teach kids to be able to, again, look at how they're processing the world and targeting particularly distortions and deficiencies in cognitive processes. Why? Because what we find is that kids that are engaged in aggressive behaviors and violent behaviors, a lot of times, as I mentioned to you earlier, they are sensitized to hostility. So a lot of incoming information, even though it's not hostile, they will see hostility and aggression, and they will retaliate, even though the intentions of the other person were not to be negative. So with cognitive problem-solving skills training, we're looking at interpersonal problems these kids are having, how they're handling social situations, thinking through the consequences of their actions, and perceiving how others feel. Again, with kids, we see a hostile intent when it comes to dealing with other people, and we want to be able to process that and help them realize that there are other alternatives other than hearing negative comments. Some of the treatment characteristics that involves this type of therapy is looking at interpersonal cognitive problem-solving skills, looking at their attention in terms of the problem and how finding appropriate solutions, and choosing, of course, prosocial solution. And the techniques that we use will be modeling or direct reinforcement when the person is engaging in positive behaviors. And it would start with games, and then eventually we'll start graduating in more kind of the situations that the kid is experiencing in their school or home environment. So here we have some illustrations, of course, working with kids, try to get them more involved, pay more attention. Using illustrations helps with that. So teaching them about the cooling down process, realizing, first of all, learning when they start getting angry, learning how to cool down their bodies and feeling more relaxed, how to engage in cool down thoughts, kind of relaxing thoughts. It's okay, I can handle this, I'm going to try to relax, I'm not going to get it to me, and do something to solve the problem. And of course, the idea would be that they would choose a prosocial solution. So what are you supposed to do? Looking at the possibilities, concentrating, focusing in, and deciding what is the best option, making the right choice, and evaluating the outcome. So if I do this, what would happen? If I do this, what would happen? So the idea is also with this process is you deter or you slow down impulsive responding. So reflective responding. You're getting the kid to start thinking through and counting through and eventually cooling down before making decisions. Show you part of the clip that is used with adolescents. Whoops.
This is ridiculous. I can't believe that she's not even going to go discuss the test. This teacher is so stupid. No wonder we all did bad. She obviously doesn't know how to teach. I'm feeling very angry right now. My head is hot, my muscles are tightening, my stomach has a cramp. Stop. I'm getting real angry here. I feel like I'm boiling up inside, and I'm thinking anger-increasing thoughts. I just need to remember getting angry isn't going to solve anything. I need to try to calm myself down by using play number 1, self-talk. Okay, I can't let her interfere with the rest of my day. I have a big game tonight. I need to calm myself down and put things in perspective. This is only the first test. I can do better next time.
My parents are going to kill me. I'm definitely not going to be able to go out with my friends this weekend. I'm going to be in so much trouble. Stop. I can feel myself getting real mad. I'm feeling my body getting tense and my face getting hot. I'm thinking anger-arousing thoughts. I need to slow down and try play number 2, relaxation. I need to calm myself down. Okay, let's take some deep breaths and loosen up my shoulders. Yeah, that feels better. Maybe my parents will understand. It's not like I flunk tests all the time. I just need to sit down and talk to them about this calmly. I can do it. I handled this well.
This test was so unfair. She asked about things that we didn't even talk about. She makes me so mad. Stop. I'm getting myself way too worked up and angry. My heart is racing and I feel like I could just scream. I'm thinking I just want to stand up and let this teacher have it. Wait. I need to stop and think about this. I'll try play number 3, problem solving. Okay, I need to stop and think about my options. My first option is to get angry about this and do something stupid. My second option is to review the test, find out what I'm doing wrong, and talk to Mrs. Jones after class. Now I need to evaluate my options. If I go with option number 1, get angry and cause a disruption in class, I can get in a lot of trouble. and even get suspended. But if I go with option 2,
I guess I stopped it because you get an idea, again, looking through the different steps and helping the kids identify times that things start heating up and how to get themselves to think about solutions and the consequences of the solutions. What I have here is the cognitive problem-solving skills were initially taught to older kids and adolescents, but there's been no more effort in the last 5-10 years to develop programs that would address younger kids. And by so doing, using puppets in the process and using cartoons to be able to reach out to the younger kids and for the younger kids to be able to understand the cognitive skills training. So for example, here, we have situations where there's role play. While his mother is angry at him for breaking her vase, discussions should include why do parents get angry? What do parents do when they get angry? Does that mean they don't love you when they get angry? How to respond with their anger? So again, using role-playing with little kids to be able to engage them in the process of developing solutions and not acting out. So when the parent gets angry, they get angry themselves. Continuing here, we have looking at everyday situations, encouraging kids to think about everyday situations. In this situation, Wally just yelled at his friend, Freddie, for dropping his special model car and breaking it. What can Wally do? What can Freddie do? Think about what solutions you would suggest to them. So again, looking at everyday situations and social situations. Freddie has invited a friend over to his house. However, his friend doesn't want to do anything he wants to do. What should Freddie do? Punch him out? Or show an adult what you would do or say. Now, outcome studies about cognitive training, skills training, have shown, again, a significant reduction in aggressive behaviors at home, at school, in the community. And also this, in terms of outcome, we've seen those gains being maintained a year later. They're seen to be more better for kids older than 10 to 11 years of age. And again, I don't know to what extent this is due to the cognitive development of the children that are more likely at these ages to respond. But also, it remains to be seen with these new programs that have been put in place, trying to reach out with cartoons, the younger kids, what kind of data we'll be getting and to what extent this approach will be helpful also with younger kids. Some outcome predictive factors, the factors that are listed there are more likely to, factors that are present, these factors that are present are more likely to predict lower outcome. So if there's comorbid diagnosis, if there's academic delays, academic dysfunction, lower reading achievement, and you can see here how cognitive processing can make a difference because the kids having difficulty with school and perhaps also having difficulty utilizing the cognitive skills training. And here are some resources that I have found helpful for either suggesting parents to get or for clinicians to have. And I think it's in your handout. And we're moving on to the third established treatment for violence and aggression, and that's a multisystemic therapy. And this kind of therapy, again, looks at changing the number of systems, including the family, the peer group, schools, and neighborhood, within the behavior is embedded in. So the idea is that you change the whole system, you're not focusing on one behavior. And so a lot of times what they're looking at is how dynamics within the system can influence the behavior. So for example, if one of the parents is aligned with the child, how it can compromise the disciplinary attempts of the other parent. So being able to target all these dynamics that may be present that may influence the problem behavior. And multisystemic therapy involves, it's a package of interventions, and we use it for both kids and the parents. What we see with the characteristics of this approach, again, we're targeting, it's been used primarily with severely delinquent adolescents and those that are repeat offenders. And the goal is to try to decrease negative interactions, try to build more cohesion and family warmth, and also because it's multifaceted, it borrows from parent management training, cognitive therapy, family therapy, and so on. And it's an intensive treatment, and therapists or organizations that provide this kind of therapy, they would have therapists 24 hours 7 that are available, that are working with any one family at a time. What are the theoretical underpinnings of all the multi-systemic therapy? Again, it's based on the systems theory. Again, the whole is considered to represent more than the sum of its parts, and looking at the behavior within the context that it occurs. And the idea is to try to implement change and provide therapeutic techniques for the kid within the system that the child is in, so within the home, the school, and the community. What multisystemic therapy does, it looks not only at proximal causes, and proximal causes in this context are referred to, let's say, if we have a kid that has ADHD, also we find out that has poor social skills. He also happens to be in a class that the teacher is very authoritarian. He's sitting with kids and associating with kids that are troubling. And also the parent support is inefficient in terms of how the school is trying to apply discipline to try to curtail problem behaviors. So that would be the proximal causes. And with the multisystemic therapy, what you would do is we start looking for also from the school side and see to what extent the distal causes will be, yes, the parent doesn't support the school, but there's a long history of conflict between the school and the parent, and also the boyfriend of the mother perhaps doesn't support the mother with her own disciplinary approaches, and how will you intervene to start changing the dynamics within this context. And I have a case example I would like to read to you, and as I read about the problems, I would like you to think about all the risk factors that we talked about, and think about all these different levels that we could intervene. So Tammy is 13 years of age, 8th grader, Caucasian, who lives with her unemployed, drug-addicted mother, her mother's boyfriend, and 2 younger sisters, aged 7 and 8, in addition to the daughter of one of her mother's drug-addicted friends. Tammy was referred for multi-system treatment because of ongoing physical violence at home. She was arrested several times for assaulting family members. At school, she beat a classmate with a stick and threatened to kill a teacher. And in the neighborhood, she was arrested twice for assaulting residents of her housing development. Many of Tammy's aggressive acts occurred following all-night drunk binges by her mother. Tammy primarily associates with delinquent peers, was recently transferred to a classroom for behaviorally disordered students, and was recommended for expulsion from school at the time of the referral. The family resides in a neighborhood with high rates of crime and violence. Source of income is from welfare benefits. So again, I'm sure you identify a lot of red flags in the history of this patient. Can I have a couple of people telling me some of the things that stand out? Karen, you're the victim, I know you.
A drunk mother.
A drunk mother. What else? What else comes to mind thinking about that? John?
Certainly living in a violent neighborhood, so there's a peer influence factor there. Mm-hmm.
That's right. So again, the drug addiction, school problems, the kid, the mother has, to the extent that the mother is drug addicted, how much presence he is in terms of being available for parenting or curtailing problem behaviors. Then we have another child that is present in the house, how are the relationships there. So in the multi-system therapy, what one would do is we'll jump in and start looking at making 2 lists, the pros and the cons, the positives and the negatives. And it may be that the positives are that Tammy enjoys sports, and Tammy is attractive and likable. She has a good personality. She's of average intelligence. That's a positive. Cares a lot about her mom, and also wants things to be better at home. And also responds well to praise. These are all positive, individual positive factors. The negative factors, of course, would be the violent behavior and the mother's substance abuse. When you look at family, you want to see to what extent is extended family present. And you find out that perhaps the aunts and the grandmother are very much concerned about Tammy, and also about the daughter, her mother, that has this kind of problems. You find out that they're willing to jump in and provide relief So therefore, if there is conflict between the mother and the daughter, then the daughter can go to the grandmother's house. Or the daughter, because she likes sports, you can sign her up for her to be able to attend to sports activities after school. Or when the mother is binging in alcohol, then with drugs and alcohol, then she can leave the house and stay with her grandmother. So again, looking at all these parameters and identifying what is going on within the whole system and how you can implement changes and prioritize the change, because obviously there's a multitude of changes that you can teach parenting skills to the mother, help her with the substance abuse, et cetera, and how to implement all these changes to be able to change the trajectory, this poor trajectory that this kid is going into. What do we know about multisystemic therapy is that, again, the data have looked at delinquent adolescents, and as I mentioned through this case history, a lot of problematic adolescents with incarceration histories. And what they've shown is that there is a reduction both in delinquency and emotional and behavioral problems and also bettering family functioning. And there's been follow-up studies studying multisystemic therapy. Again, it's a lot of interest because it's also very expensive. Follow-up studies 2, 4, and 5 years later and have shown positive results. And also with adolescents having engaged in multisystemic therapy, they have shown that a lower arrest rate and recidivism. I want to point out also that the fact that this kind of therapy is used with severe cases, this is a test in its own right, because here you have this chaotic situation and then you are able to bring about change. Also, what you see is that even kids that, when it's not violence involved, but perhaps their sexual offenses or drug use, multisystemic therapy has been found to be helpful. Also among abusive or neglectful parents. And you can see why, because you don't care so much. It's not parent management training, so you have a parent that doesn't care. Even if the parent doesn't care, then you go to the extended family, you go to the school, you go to all these other places to try to bring about change. And here's some information to track down for learning more about multisystemic therapy. Conclusions, again, the 3 interventions that are highlighted here are among the most well-established treatment for violent behavior, for conduct disorder, and all of these methods have had controlled trials, they have replications, and they have outcome data. And again, the question then is, okay, which is the best? What should we use? What is the good idea to use? And here I have some tentative guidelines, and the reason I call these guidelines tentative is because really these different approaches have not been compared side to side. There's been a lot of data, but not comparing PMT to MST to problem-solving skills training. So what we know so far is that PMT is parent management training has shown extremely good data for pre-adolescent children. On the other hand, multisystemic therapy, we have found there's a lot of data to support its use with older delinquent adolescents. And finally, with problem-solving skills training, has shown benefits for both children and adolescents. Then we go on to treatments that may not work as well. And the idea of what such treatment would be those treatments that tend to not to ignore the multidimensional nature of the problem that we have here. As I mentioned earlier, when we started with the risk factors, you can see how many components contribute to problematic behaviors. So if we ignore all these components, we're not going to see change. So treatments that may not work as well include psychodynamic therapy, relationship-based therapy, play therapy. This, and I say, may not work as well, again, because we don't, therapeutic techniques have not been really tested, so we don't really know about their efficacy. Some studies have used some of these treatment techniques as comparisons and approximation of these techniques and showed that MST or PMT are more likely to be better, but really there has not been very good studies that would really challenge these therapies and seeing to what extent they could be efficacious, provide efficacious treatment. So the idea I hope that you're getting from all this is that we need to pay attention to the multiple. When we apply psychotherapy, we need to apply the therapies that we know that they have shown good support, and also trying to look at the multiple domains. Group therapy, and I put a parenthesis without healthy social peer involvement because I wanted to qualify, because a lot of times with cognitive skills training, it's applied with children and with adolescents in a group setting. And that could be very helpful. However, what studies have shown is that if you start collecting a bunch of adolescents that have a conduct disorder diagnosis, or they're aggressive, they're violent, you put them together, then you don't see a lot of change. And a lot of times what you have is more combustion, in that kids are fitting to one another. Whereas there have been some attempts where they're mixing groups, so they will form groups that some of them are referred in because of violence or aggression, but the rest of them are there for other reasons. Why? Because in the group setting, there is the bonding with your peers. So to the extent that you're going to be bonding with troublesome peers, then you're going to have perpetuation of the troublesome behavior. To the extent that you have prosocial peers around you, and to the extent that these prosocial peers have been rewarded by the leader, etc., you're more likely to want to be more like them. What we've learned with research, again, in learning more about aggression and violence and how to change things for these kids, is that a lot of times there is an early termination, that we have a lot of dropout. And there's some studies that have report dropout as much as 40 to 60%. And also that, so then one attempt that we have to put in place is that kind of trying to be able to change to keep these kids, these families, more in treatment. And also we know that by including supervision and involvement of caring adults outside the family, multi-systems therapy shows us that that provides good change. I have here some information about school safety. I have some sites here about indicating school safety information, information about violence prevention within when there is assault, if you're dealing with adolescents or kids that have been assaultive, and some other websites that could be of use. So that's it. Thank you. And are there any questions? Yes.
Fantastic talk. Just in a practical sense, just to take our community for an example, where is there a clearinghouse for what's available for these kids at risk, and who ultimately ends up being sort of the director of all, especially if you do this, the systemic approach, who practically ends up being the head honcho?
That's a very good question. I've seen some, we are not in our clinic, we're not going to be dealing as much with this kind of a population. So that will be more kind of a CPSA territory. But I've had situations of families that would come through the anxiety clinic, and then I would hear that this family was already in this program because they were very poor, and at some point the mother was on welfare. They were in this program where therapists would come to the house and help her in the house. Or other family that came in and the mother was CPS was involved, had taken the kid away, and she would say how, in addition to coming to see us, there would be a worker that would come to the house and teach her parent management techniques. So, so my understanding is that for this, with CPSA, the kids that have been, kids that have been identified as being really outliers, there are these interventions in place. Obviously, we're in Arizona, so we are not expecting a very thick social support net. Yes. And of course, targeting with MST, as I mentioned, it's an expensive therapy. The therapists could have, there could be 2 or 3 therapies that are assigned 10 families, and they're assigned for them for a 5-month period. and they're on call in a sense 24/7 that are available for these families. So in order to pour in these resources, obviously you have to deal with a kid, as Tammy, that was very assaultive, that she was really off the edge.
Can I add something?
Yes.
Some of the states, they have put some money, like they had a contract with the people who do the MST. I don't think they do in Arizona, but like Fontano or La Frontera and Providence, they do have some home-based kind of treatment, where the teams go to the home and the community work with the kids. So they use some of the same principles.
Statewide, I think they call it the Child and Family Team Meeting, and that's where the multi-systemic should develop within that forum. The problem is getting all the parties that should be there present so that they can put a plan together that is effective.
Where's that child and family thing happen? Or who does that?
It's usually facilitated by that Providence, Pantera, or La Frontera. So the providers under CPS. So essentially you have to be in the system as a client to get that service. So.
And I mentioned to you kind of a part that so much the dropout rate is so high. And I don't know if I skipped the slide where it indicated the factors that come into play. Of course, when we have severity of dysfunction, chaos within the family, comorbid conditions, drug abuse, etc., these are the reasons that would lead to dropout. And of course, as we saw with area studies, these are also the reasons, the components that predict poor outcome. However, there's been studies that have looked at families that are as dysfunctional with families that dropped out but stayed on. And they've shown that these families saw more benefits. And of course, when the other families that drop out, they still have some gains, but not obviously the full gains that you see with the families that were as dysfunctional but stayed on for the whole treatment. And I'm sorry, there was a question back there. Yes, Mark?
Thanks also for the great talk, Dr. Gonzalez. The outcome predictive factors, do we have any most recent research showing single parents versus staying in distressed families? Is there any
single parents
versus staying in distressed families? In other words, families that break up and we have a single parent versus kids who are staying in families who are distressed in terms of outcome.
That's a good question. The only approximation to this question is data on divorce and the effects on children that have shown that kids that stay in troubled marriages, that there's a lot of conflict, do worse than kids that their parents divorce. So obviously the conflict that exists in a household, even both parents stay together, but there's a lot of conflict that affects the kids adversely.
Does that relate to aggressivity as well?
To recidivism?
To aggressivity, to...
Well, again, looking at, I don't know about specific data that look at all these multiple factors, but when you look at individual factors, that will be a risk factor. When there's a lot of conflict at home, the kids will be acting out. And a lot of times kids will come in, well, he started doing this and this and that. Then you start asking more questions, and, well, the parents are discussing divorce, they're fighting in front of the kid. And, of course, for the kids, the younger the kid is, the parent is all their world. You know, for us, we have our work, our friends, our family. For the kid, the 10-year-old, the parents are 90% of the world. So when the world is falling apart, the kids are falling apart. Yes?
It is the most aggressive or the most juvenile delinquents, if you look at who are involved with the legal system, they really don't have any parent. Most of them maybe live with a grandparent or in foster care. Fathers, you know, they are in jail, and mothers may be in drugs, or one of the other parent is not there, dad died, you know. So they don't really have any kind of parent.
One of the things on your slides that I noticed that I think maybe you didn't even mention is treating the depression in the parent, or treating the psychopathology in the parent. And I think sometimes in child psychiatry, it's difficult to get around to assessing or persuading the parents to get treatment. It sounds like the multi-systemic addresses that, but I wonder if
directly, a lot more directly than you're able to do when you see the child and you start seeing that the mother has issues that are left unaddressed.
Is there evidence specific to treating the parental depression
The way I respond to that is at least how we train child fellows and psychology interns here. We use a lot of parent management training, particularly as the kids get younger. So that means that the younger the kid, you'll be spending time with the parent, and then you start finding out by talking to the parent either that he's overly pessimistic or very irritable, and then you start gently suggesting to them, you know what, you're going through a lot. Have you thought about talking to someone? It seems to me that you may be depressed, you're under a lot of pressure. So encouraging. So through parent management training, you have the opportunities to also assess the parent and the contribution of the parent's pathology to the kid's problems. Yes?
What percentage of parents cooperate with the teacher as regards to grades and misbehavior these days? In the old days, there was almost 100% cooperation.
Okay, well, those days are over. So I would say what you see now, sometimes parents would come in, and even though the kid is engaging in problematic behavior, they're reinforcing, they're supporting the problematic behavior of the kid against the teacher. To tell you the truth, and of course I have a bias, I don't know about studies that have looked at it more systematically, because my biased perception is seeing families that are troubled, and they come to me because they're troubled. So I may be seeing the percentage of the parents that they have these polemic interactions with the school. We had a mother that we assessed a couple of days ago, and she says, the teachers tell me that my kid needs to be on medication. I think he's just overactive, and the kid is a menace. But nevertheless, the mother is very tolerant and is against the teachers that are pushing medication on her child. But again, I'm at the point that I see the problem situations. So I don't know data to tell you. Any other questions?
I have a question about the MSP. I know they have applied this to, conduct disorder, aggression, and also severely psychotic patients to prevent temptation. Was there anything have they looked at children or teenagers who really kill people? Is there something for them? What kind of treatment?
I'm sorry, children?
The children who have really murdered, we had recently 2 kids here in Arizona, very young kids. I don't know if there are any kind of studies on those.
Unfortunately, I'm sure there are studies. These are case studies and kids that have been looked at, but I'm not familiar with the literature, so I won't be able to answer this. Does anybody know? Any other questions? Yes.
Are there studies out there that actually show that group therapy or even grouping kids, particularly adolescents, that if you group more adolescent kids together, you tend to exacerbate the agitation and the aggression and the problematic behavior?
So yeah, the groups, again, one of the treatments that haven't been found to be very helpful is, again, groups that cluster kids according to problem behaviors. So clustering kids that are violent and aggressive all in one group, because then they feed with one another. And that doesn't apply only to aggression, because I have kids that they would say that they went to the juvie and they said, well, how I learned a lot more different ways of, acting out and doing, illegal things.
That still group the problematic kids together in one
It's
class.
convenient and economic, I guess.
Resources.
Unfortunately. There are also schools that what they do is they assign an older kid that is not problematic with a kid that is problematic, and they call them the peer buddies. And by so doing, trying to help the younger kid emulate prosocial behaviors that the older kid is displaying. Yes?
This reminds me that about 400 years ago, there was a study at the University of Hawaii showing that the best results for these kids were either going into the military or forming some religious or other community. Is that anything more recently showing what happened? In other words, structured community
Yes,
involvement?
absolutely. And it's been some outcome studies. Typically up until 5-10 years ago, I would say, studies have concentrated in troubled behaviors. Kids at risk, kids of alcoholics, kids of violent criminals, et cetera, et cetera. So now there's been some work that is coming out and being published of outcome studies that looked at kids that did well. Kids are coming from problematic families, and it's not that we're going to drop them and not study them, but we want to look at these kids. What worked for them? Why are these kids doing well? What are the protective factors, so to speak? And what you're saying is one of the protective factors that has been identified, in that kids that have someone at school, a coach, they have an affinity of a sport, and they have someone, a role model at school that gets them under the wing, are more likely to have a positive outcome. Kids that go to church, kids that have religious affiliations, sports affiliations, are more likely, again, to connect with a pro-social group and therefore have less time to devote with an antisocial group. So yes, this is factors that have been shown with research that are protective and work well. Any other questions? All right, you're a wonderful audience. Thank you.